we'll go ahead and get started. Welcome everybody to the Retina Consultants of Texas CE talk this evening. We have a very exciting lecture we're going to be giving tonight. Dr. Fan will be presenting for us, and we'll kind of get into the introduction for him here in a second. So just so everyone knows, your CE credit has already been captured by your registration for the meeting tonight. So we will submit that 1 hour of credit to the TOB. We will have some upcoming CE dates over the next couple months, and they will be posted online. So make sure to check retinaconsultantsoftexas.com for all of the upcoming lectures to make sure you get your CE credits for the rest of the year. So we are RCTX. We're the largest retina-only practice in Texas. We're home to RCA Research, which is the largest retina research center in the United States. We do a lot of clinical trials here in our practice. We have 3 major research hubs at our Newcastle Bel Air location, in Katy, as well as in Woodlands. We specialize exclusively in retina and diseases of the retina, vitreous, and macula. We have 25 physicians and 23 locations between the greater Houston and San Antonio areas. So our commitment, we are a retina-only practice. We do not have an optical shop. We don't do glasses. We also don't treat glaucoma or cataracts. We're committed to kind of co-managing patients with you, see them taking care of the retina problems, and getting them back to you for their ongoing ocular care. So a couple of updates from us. We are currently serving 14 locations throughout the greater Houston area. Our Livingston location has a new upgraded office that we're seeing patients in, and our 1960 office is changing locations to a newer, more spacious, bigger office that we'll be starting in just next month. So here is a picture of that. So it's going to be located in Vintage Park. This is a cool new initiative of RCTX. So we're trying to do a different flow pattern for our patients here. We're trying to do remote workups for these patients before they come into the office to try to improve the flow, increase the amount of time that patients can spend with the doctors rather than in the workup rooms. And so this is kind of a little paradigm shift in how we are moving patients through our clinics, and we're excited to implement it here at our new Vintage Park location. The San Antonio area, we have 9 locations. We also have a new doctor coming on board in San Antonio later this year. It's Dr. Carson Petrash. We've been interviewing him for a while, it seems like, and we're anticipating him joining our group up in the San Antonio area. So excited to have him come on board. So without further ado, I will give an introduction to a man who needs no introduction. We have Dr. Kenneth Fan speaking to us tonight about a new investigational therapies for Stargardt's disease. So Kenny is one of my best friends, and he's had a lot of amazing accomplishments in life. He went to Dartmouth for college, went to Boston University for medical school, and then I met Dr. Fan at Bascom Palmer Eye Hospital in Miami, and that's where he completed his ophthalmology residency as well as vitreoretinal surgery fellowship, and he served as chief resident of Bascom Palmer as well. So Kenny was always 1 year ahead of me in training. So he's been a mentor and a role model for me when it comes to medicine and being a retina surgeon. We've also become really good friends. He's a large reason for myself, and I think also for Dr. Alkerson, while we both came out to Houston to join RCTX. And a couple of fun facts that people don't know about Dr. Fan. So he cuts his own hair, and he's very proud of that. That's why he looks so sharp all the time. He's also refused to cut my hair or anyone else's. He is a big-time chef. He makes the best and only Spam musubi that I've ever had in my entire life. And he owes us some dinner here sometime soon. And his son, Lucas, also beat me in a tricycle race, which I'm very embarrassed by, but also proud of at the same time. So those are the funny things, but in all seriousness, Dr. Fan has become our specialist that treats patients with inherited retinal disease. He's brought a lot of cool new clinical trials to our practice to help our patients who get access to potential therapies for these diseases that never had a treatment previously. He's going to be talking to us about some of that tonight as it applies to Stargardt disease. So I'll let Dr. Fan take it from here.
Thanks, Patrick. Yeah, thanks for those special facts there. Cooking for Dr. Starpoli is more difficult than it sounds given his gluten allergy. In addition to being a NASCAR driver and a retina specialist, world renowned, I might add. Um, yeah, let's get to it. So, uh, if you guys could give me a thumbs up with the slides, you guys can see that. Okay, thank you, Rosa.
Yep.
Yeah, so I'm Kenny Fan. I was just looking over the attendee list. It's really an honor and a pleasure to be sharing with you guys today. Something that I spend a lot of time on. I really care a lot about, and something that's very challenging in the field of retina. I appreciate so much all of the referrals that you guys send. I have clinics, as you guys may know, in Bel Air, Cypress, Woodlands, Katy, Memorial, and I have some satellites as well. But I'm just perusing the list and I see so many awesome referrers, and you guys have just been um, basically comprising the bulk of my inherited retinal disease practice. So without you guys, it would truly not be possible. And I love texting with you guys and sharing my thoughts. So please feel free if you ever need anything, just reach out. Um, so yeah, I'm just gonna dive right in. We're gonna first, talk about six different cases of inherited retinal diseases that I have seen in my clinic, probably referred from you guys actually. And they are actually all caused by the same genetic mutation, if you can believe it or not. Um, so the very first case is a 30-year-old male presenting with light perception vision, which is even even from an inherited retinal disease perspective, quite severe at this age. He said that he lost vision when he was 5, and initially he had lost vision at night. And then it kind of moved to reading, writing, bike, riding, and then also total loss of vision by age 10. So um, when we talk about family history, he says maybe there was a grandfather that was affected, but no other siblings or immediate family members. Here, you can see what appears to be quite widespread bone spicules in all four quadrants and even creeping into the macula. The bone spicule presence in the macula is actually relatively rare unless you're talking about something more severe and aggressive. Um, you can also appreciate maybe some early atrophy in the temporal macula. Um, but otherwise, if you were to look at this eye initially, you'd think, well, I'm kind of surprised that this patient is light perception until I show you the next slide. Autofluorescence is a huge, huge benefit in patients where you have a little bit of diagnostic mystery. I actually, if I had to choose, I would choose an autofluorescence over a regular fundus photo. Here you can see that total macular atrophy and peripheral atrophy in this patient, and now you can begin to understand why he is light perception. On the OCT, these are the best macular cuts we could get because of loss of fixation. But you can see on both eyes, there's just complete outer retinal loss and even some inner retinal loss in both retinas. Okay, so moving on to case two, which is dramatically different. You have a 80-year-old female who has pretty good vision, 20/30, 20/50. Um, her symptoms began 10 years prior and Jess has peripheral vision loss in one eye. She has no other issues, and she has two full sisters who don't have the any of the same symptoms, and one asymptomatic daughter. Again, you kind of have a unique appearance. You've got maybe some what appears to be retinal atrophy in the periphery, but very subtle. If you look quickly, what actually jumps out at you is the reddish hue of the central posterior pole in the macula, and maybe some RPE changes in the fovea. And if I advance to the next slide, you'll see that actually that central red area is in fact normal retina, and the rest of the retina is totally atrophic. And so again, we have another picture here of retinitis pigmentosa. You've got kind of the nerve is lighting up here from optic disc drusen, which is actually incidentally unrelated. But this red spot is similar to the pathophysiology of like a cherry red spot in a retinal arterial occlusion. You've got central healthy retina and then surrounding kind of dying retina. And on the OCTs, you have pretty good central preservation in both eyes. So that would explain why the patient is roughly 20/30, 20/50. Okay, case three, another young patient who is seeing 20/60, 2200, started when he was 13 with rapid progression from 20/40, 20/50 to 20/60, 2200. Incidentally, I saw his sister first and then diagnosed him thereafter. So he's got one sister who has the same problem and the parents are normal. This would be one that would be easy to miss if you really look quickly. Um, Even with a 90, it'd be hard. Here you can zoom in and kind of see some modeling of the pigment right in the central fovea, but pretty much everything else looks pretty normal. Again, autofluorescence is a great friend of yours. Here you can see an early bullseye maculopathy and increased autofluorescence just outside of the fovea. And on the OCT, you can see this sort of like chunked out subfoveal outer retinal loss, which you can see in this genetic mutation. Case four is a 48-year-old female who's presenting with 20/50, 20/20 vision. So her symptoms began when she was 32. She had gradual loss of peripheral vision and has no family history whatsoever, including a full sister, four children, mother, and a father. This is a really interesting appearing retinitis pigmentosa. You can appreciate the bone spicules in all four quadrants. There's some moderate vascular attenuation, but what's really striking about this picture is the frank and very clear demarcation around the arcades. And here you can see that there's basically this bleeding edge of hyperautofluorescence that indicates the area of transition which inevitably is closing inward towards the center vision. So this is a retinitis pigmentosa that is advancing. Luckily, the center vision remains pretty good, which would explain the presenting visual acuity. Case five, you've got and these are actually becoming more and more classic for the genotype as we go further. You have a 53-year-old male with 20/20 vision. He's mostly complaining of dark adaptation issues, photophobia, some color vision loss, but no other family history. And here you start to see what you would consider classic for this genotype. You have these yellow deposits that aren't quite drusen. They're a little more flecky, I might say. We call them pisiform flecks, pisiform meaning that they kind of look like fish. And when you go to the autofluorescence, you can appreciate that these areas of flecks are actually active RPE changes with lipofuscin deposits. And then these black areas are areas of atrophy where the patients have lost vision but don't quite realize it yet. And here's the OCT. You can see the flex kind of interrupting the RPE and outer retinal layers. Last case, this is probably the most classic case of the six, is a 59-year-old female. She's got good vision in one eye and 2200 in the other. Started around age 49. That's actually kind of late for this genotype. Um, and she's complaining of central vision loss and distortion. Here again, you can see those kind of emanating circumferential flecks in the periphery in the posterior pole. And then you have these large central areas of atrophy, which almost looks like macular degeneration, but if not for the flex and the unusual pattern of the involvement, you might think that it's geographic atrophy, but in fact, this is the same genotype, the same disease. So the genetic diagnosis, as you may have already guessed from the title of the presentation, is actually ABCA4, which stands for ATP binding cassette subfamily 4, subfamily A type 4, and it is responsible for the most common hereditary maculopathy in the world, which is Stargardt disease. And so we're going to spend the rest of our presentation talking about Stargardt. So What is Stargardt disease? Stargardt disease is the most common genetic mutation that I see in my clinic. There is one clarification. I do see more retinitis pigmentosa, but retinitis pigmentosa is caused by an amalgamation of multiple genetic mutations. So Stargardt disease is caused by primarily just one genetic mutation, which is mutations in the ABCA4 gene. I tell my patients it's between 1 in 5,000 to 10,000 people. So it's not exceedingly rare, but it is considered an orphan disease. And it's autosomal recessive. So if you've got a patient in your clinic who comes and says, hey, um, I've got the same thing that my mom has, and her mom had that, and her dad had that, and my son also has it, it's not Stargardt disease. Stargardt disease has to be passed by both parents. Both parents have to be carriers of the same or similar mutation, and they both have to pass that mutation on to the child. So, by definition, if you've got multiple generations in a row with the same maculopathy, it's not Stargardt, or most likely not Stargardt. I never say never. There's a few exceptions. As I was saying before, generally it starts in your 20s and 30s. So it's kind of a brutal disease for young patients. It can really start right as they're learning to drive, right as they're learning to navigate the world, as they're going to college, that kind of thing. Um, and as you know, it's mostly central vision loss and decreased visual acuity. So, as I was saying before, it's the most common macular dystrophy. 15 to 30% of all inherited retinal diseases are Stargardt disease. And the ABCA4 genetic mutation can cause multiple different presentations or phenotypes, as I call it, as you saw earlier from those 6 diverse cases that I presented. Um, Typically, Stargardt phenotype is the most common. So you look for those pisiform flecks. You might look for a bullseye maculopathy on the autofluorescence. You might even look for like a normal looking fundus with unexplained vision loss. Okay, I've interspersed several quizzes into the presentation. There's a series of 3. Um, and so the quizzes are pretty straightforward. Don't get nervous. So it's just, is it macular degeneration or is it Stargardt disease? And the point is to demonstrate the similarities between the two. So I think they start a little bit easier, they get a little bit harder, but let's see. So I'm gonna poll you guys. So um, let's first look at the pictures. You've got a 79-year-old white male, and you can see the OCTs on the left. You can see the fundus and then the autofluorescence here on the right. Mackenzie, we can go ahead and start the poll. Okay. Mackenzie, you can go ahead and close the poll and show the results. Great. So we've got 80% saying AMD, 20% saying Stargardt. This is AMD. And age is a clue, but it's not always definitive. This is a tough one because the central atrophy looks quite convincing, and you maybe have these flecky looking hyperautofluorescent deposits around the atrophy. Um, but yes, most of you guys got it. Okay, let's open the poll. Actually, let's let yep, that's fine. We can leave that up as long as it doesn't block the screen. This is a 76-year-old male, white male as well. Here you have a similar appearing central atrophy, and you can kind of appreciate the significance of atrophy on the autofluorescence. Okay, we can close the poll. Awesome. So flip-flop, yeah, good. This is Stargardt disease, and as I said before, age is a clue, but it's not always accurate. The severity of atrophy and the pattern in the extrafoveal and extramacular region is kind of a giveaway here. And also you can see the stippling from the flecks that have really emanated outwards towards the periphery. Okay, gonna try to put you all to sleep here with the pathophysiology of Stargardt. Actually, I just gonna briefly gloss over this slide. We all know the visual cycle and how the cis retinal has to be converted to trans and it has to be flipped over and then sent back to the RPE. essentially the ABCA4 gene encodes a protein on the outer retina, the photoreceptors, and essentially in these segments of the outer segments of the photoreceptors, the ABCA4 has to flip. It's called a flipase, so it flips over the protein in the retinoid cycle. And if it doesn't flip this protein over, the all-trans retinol, essentially it does not continue along the retinal cycle, the visual cycle. So if all trans retinol gets clumped up inside of the cell, it actually dimerizes into what we call A2E. A2E is a precursor to lipofuscin. And so the A2E clumps up, becomes lipofuscin, and then it causes photoreceptor cell death and RP atrophy and then vision loss. And so understanding how the ABCA4 protein affects the visual cycle can be helpful because then you can kind of try to truncate this damage at any point in the pathophysiology, not just targeting ABCA4, but any of the other parts. I snagged this picture not because I like it, but it's from the Prague Star study, which is the largest Stargardt observational study ever performed. And essentially, you can see in that sort of like vomit green there at the bottom, it's the lipofuscin deposits that are damaging the outer retina and underlying RPE inside the retina. And those that's kind of where you see those flecks. Okay, we're going to do our second set of quizzes. Um, so this is a 77-year-old white female. We can go ahead and open the poll here. All right, let's go ahead and close it. Okay, this is a tough one. This is actually Stargardt disease. We can close the poll. Um, the biggest thing is the intensity of the hyperautofluorescent flex just adjacent to the atrophy. But this patient was indeed tested and genetically proven to have two ABCA4 mutations. Okay, this is yet another one, a 75-year-old white female. You can see the extensive atrophy and the autofluorescence that is shown on the side. Go ahead and open the poll. And we'll go ahead and close it. Good. Yeah, so this one is actually macular degeneration. Um, this patient was tested and negative. This is a tough one. The pattern of the atrophy is very, very severe and slightly atypical for macular degeneration, but you can see that it kind of emanates outward, and you don't typically get this extensive extramacular atrophy in Stargardt, not at least in these small little patterns. And you also are kind of appreciating an absence of hyperautofluorescent flecks on the autofluorescence. So this is a super tricky one, but this actually indeed is macular degeneration. Okay, so as we talked about before, there's multiple features and lots of different presentations of ABCA4 genetic mutations. Here you can see this is the primarily fleck pattern phenotype. The middle one would be sort of your more classic atrophy-based Stargardt. And then the right side is the extensive end-stage Stargardt disease. One thing that I love to mention is the diagnostic confusion between late onset Stargardt and macular degeneration. I feel like we miss this a lot, even as retina specialists. Um, a study found that 22% of late onset Stargardt disease, so patients who are diagnosed, in their 50s or 60s, are misdiagnosed as age-related macular degeneration. And the quote from the paper basically says that, um, they end up receiving unnecessary invasive treatments, whether that's anti-complement injections or suspected wet macular degeneration injections. They miss the opportunity to engage in research opportunities to slow down progression of Stargardt. So yeah, 22%, that's a very high number. And in the field of IRDs, there's a lot of mimickers and masquerade diseases. This is a patient who was being treated for macular degeneration who actually had Sorsby's fundus dystrophy. So you can see how similar all kind of this macular degeneration and Stargardt can look. There's central atrophy with these yellow deposits everywhere. This is a patient who was being followed for geographic atrophy with PRPH2 macular dystrophy, which is what we call pseudo Stargardt. This is a real tricky one. PRPH2 is autosomal dominant, so this is one of those diseases where grandpa, mom, patient, and son might all have the condition. But you could see that there's also flex and there's also atrophy. So this is actually very similar to Stargardt disease, but not quite. And this is best vitelliform macular dystrophy. This patient was being treated for wet macular degeneration, and then when I ended up seeing them, realized that in fact they were best one positive and could stop their injections without further damage to their macula. Okay, this is our last set of quizzes here. Okay, this is a 60-year-old white female, um, so a little bit younger. You can see that there's also modeling of the macula. There's some atrophy. We can go ahead and open the poll here. Let's go ahead and close it. All right. Pretty good. So this is Stargardt. I think you guys are catching on, but there's that deep, what we call it, definitely decreased autofluorescence. So it's like very dark atrophy in the center with these hyper autofluorescent flecks. Okay, this is the last one. 76-year-old white female. Let's go ahead and open the poll. All right, we can go ahead and close it. Great. Good job. So yeah, so this is macular degeneration. There's a couple of features that kind of speak to that. There's a sort of a circumferential growth of the atrophy without involving the fovea right away. On the autofluorescence, you can see a very subtle hyperautofluorescent edge to the atrophy, and then there's the absence of those really bright flecks on the autofluorescence, so that kind of also gives it away. So this is actually macular degeneration. Okay, so this is one of the areas that I think really motivates me and drives me to um, keep seeing the patients that we see and try to do as much as we can for those patients, which is the area of research and future treatments for ABCA4 related disease. Um, so the number of active interventional clinical trials for ABCA4 right now is 12, and the number of FDA approved therapies is 0. And in fact, there's probably been 20, 30 prior clinical trials for ABCA4, all of which have not come to fruition. So this is a very, very tricky and difficult space for drug development. Before we dive in there, I just want to show a video of what gene therapy is really like. I think it can be confusing, especially visualizing, the retina and then what it's like to inject. Where do we put it? Do we put it in the vitreous? Do we put it in the retina? So this is actually a surgery performed by Dr. Wyckoff in a recent ABCA4 Stargardt gene therapy. Kind of walk you guys through this. This is not sped up. This is real time. Um, the, Basically, we're in the eye in the middle of surgery. These patients are young, so we have to establish where the vitreous is. The vitreous can be very clumpy and sticky and prevent the gene therapy from getting inside of the eye. And here you can kind of see that shine of the vitreous kind of getting lifted up as he tries to remove all the vitreous from inside the eye. This is indeed the cannula that we use to enter the retina. It is a 41 gauge cannula. So intravitreal injections, we usually use like a 30 or 32 or 33 gauge needle. This is a 41 gauge. So yeah, it's very easy to bend or break when you stick it in the eye. Um, so essentially what you do is you prime the injection and you enter into the retina and you inject. And the OCT can be seen here on the right side of the screen where there's an elevation of the neuroretina with injection. And that's how you know you're in the right spot. You don't need an OCT, but it does help just confirm that you're placing the gene therapy into the right space in the retina. And typically with these studies, there's a target amount of gene therapy that you want to deliver for it to be successful. And so in this case, you have to make a couple of blebs with the DNA inside. And here you can see the blebs coalescing. And in this case, we wanted to detach the macula slightly because that's where the action is, and that's where we want the gene therapy to protect the eye. Okay, so I mean, easy, right? You just get the gene and you stick it under the retina, but no, it's actually extremely difficult because of the nature of the disease and all of the hurdles, both regulatory and scientific, that we have to go through. So the first one I beat like a dead horse, but ABCA4 is so hard because there's different presentations, different severities. In one patient, it can be horrifyingly damaging at a very young age. In other patients, it could be pretty much asymptomatic until age 60. So, how do you measure progression? How do you see how patients will respond to a treatment, which patients actually need the treatment to prove that it's effective and it's actually helping those patients? So the genotype, phenotype heterogeneity is a huge issue for ABCA4. Another thing is, when we inject the medicine into the eye, we're not injecting like literal just ABCA4 DNA. We have to inject the DNA encapsulated in a delivery mechanism, which we call an adeno-associated virus. And the AAV can only hold 4.8 kilobases of DNA. And ABCA4 is indeed much bigger than that. So you can't put the whole thing in the AAV. So how do we actually deliver it? So there's alternate approaches to delivering ABCA4. The one of the more simplistic solutions is to simply cut it in half and only deliver the first half of the gene. But if you deliver only half of the gene, well, you better hope that both of the mutations are on that half of the gene. And if you don't have both mutations on that half of the gene, then you are not eligible for the treatment. So that actually ends up excluding quite a few patients from a study like this. You can also deliver two AAVs at the same time, and half of the gene is in one and half of the gene is in the other. And then you have kind of these proteins designed by people much smarter than I am that then find themselves together and recombine inside the cell. This is due to splicing and recombination. So this dual approach is actually being developed now and rolling out to patients for the very first time. There's like two or three companies that are just coming to market with this. I shouldn't say market. They're basically entering to phase 1 clinical trials with the same technology at the same time. And then there's other viral vectors that are not as validated, not as proven. We don't know if they cause inflammation or if they are as effective in delivering DNA. They're called lentivirus, and the lentivirus has a much larger capacity than an AAV. And so, yeah, as you can imagine, this is very challenging for scientists, and it makes the landscape a lot more difficult. And actually, it's not just relevant for ABCA4, but for many genes in the inherited retinal disease space, including common genes for retinitis pigmentosa like Usher2A. So the third challenge is regulatory. As you have seen from all the different patients that we presented, there's it's not fair to just test ETDRS visual acuity on all of these patients as a marker of improvement or how they're doing. So in some cases, it's very representative of the severity of disease, and in other cases, it's not. In some patients, they have not lost that very small central island, so they can read 20/30, but then most of the stuff around the macula is all gone. And so those patients, you test them from visit to visit and they see 20/30, 20/30, 20/30, but they're telling you, hey, I'm getting worse. And when the lights turn off, I can't see. When I go outside, the sun is too bright. I can't grab things. I don't have stereopsis. And so how do we measure uniformly across all patients in like a clinical trial, the actual true progression or response to a treatment? This is a challenge in inherited retinal diseases, also in other clinical trial design and protocols too, like for geographic atrophy, but especially in inherited retinal disease like Stargardt and retinitis pigmentosa, it's very, very challenging. Um, some of the things people have looked at is just measuring the lesion growth over time, but sometimes the lesion growth is not related necessarily to visual function. And in Europe, they have actually said that's what they believe. They don't think atrophy growth size is an approvable endpoint in Europe, so they don't approve drugs that only limit lesion growth, but not vision, for example. You could look at photoreceptor loss, measure that on every single OCT and see how that changes over time. You can look at low luminance vision, so not visual acuity, but when the lights are turned down, what that vision then is, and if that changes. Microperimetry is a test that we do. It's similar to a visual field, but it's a little more cumbersome and a little more difficult to perform. But people have looked at microperimetry, and a lot of clinical trials have failed trying to prove improvement on microperimetry. Reading speed is also kind of a so-so test, but at least it tests true functional change over time. It is what it sounds like. You're basically just reading and seeing how fast you can read as compared to prior or as compared to other patients. So the last segment of my presentation is just on the development in Stargardt disease. So don't get overwhelmed by this slide, but essentially, this is the visual cycle we talked about. And all of these blue X's are areas where scientists and companies have developed treatments or are aiming to develop treatments for Stargardt disease. I kind of put together this very simple slide that shows where we really are right now in the landscape of Stargardt. So we've got one company that is pushing into phase 3 or already in phase 3 for an oral treatment for Stargardt. They inhibit one of those proteins in the eye that reduces buildup of lipofuscin. And then we've got a company that's passed their phase 2 who's already submitted to the FDA with an oral treatment as well. And we do know that A2E and the dimerization of those molecules is provided by dietary and supplemental vitamin A. One thing I tell most of my patients is that if they have Stargardt, avoid taking vitamin A. And so this company is looking at modifying vitamin A so that they don't clump together and dimerize and cause lipofuscin buildup and then damage to the retina. Then we've got a bunch of phase 1, 2 studies. This is not all of them. This is just some of them looking at editing exons, the dual AAV approach. Um, uh, there's a company looking at modifying genes, not specifically ABCA4, but around ABCA4. They called it a modifier gene therapy. And there's a company looking at oral metformin as a protective mechanism for Stargardt. So this slide is a lot, but this actually includes all of the current treatments under study in research clinical trials for Stargardt. We are involved in these right here. So we don't have all of them, but we have quite a few of them. And we're proud to hopefully get even more of these studies into our clinic. Um, Specifically, some of these treatments are surgery, which can be scary for patients, and some of them are just an intravitreal injection in clinic where they come for, a quick 1, 2 hour visit and you just give the injection. Um, the two injections are these two bottom red circles. It's a technology called optogenetics. The way I describe optogenetics is essentially you're delivering a light switch protein to the retina. The retina absorbs this protein, and the protein turns on when the light hits it, and it turns off when the light turns off. And so the protein then can send signals down the ganglion cell and bipolar cells to the optic nerve without the photoreceptors. And so we are indeed treating patients with these medications already. So if you have patients who are sort of near the end stage. They have very poor vision, photoreceptors are gone, but they still have a decent inner retina, like ganglion cell, RNFL. then these studies would be really great. And I'm actually really excited for these studies because otherwise, patients at the end stage of Stargardt disease have no other option. No trials will enroll them, and they're typically very kind of hopeless. This is the second page. We've had this study, well, I'll call it Izervay, in our clinic, which was initially used for geographic atrophy, but they were hoping it might be effective for Stargardt. The results have not been read out yet, but yeah, this is just I think very encouraging to see the number of studies um, that are currently under study for in trials for Stargardt. The one thing I will say is this paper and this chart, I did not create this. This was published out of Bascom Palmer by one of my mentors, Nell Grigori. So it's a very comprehensive chart. And if you guys ever want to take a look at it, I'm happy to share the paper with you. Okay, so just in summary, the future is bright. I really think that this is seriously probably the most studies we've ever had for Stargardt, like in the history of gene therapy or treatment and clinical development for Stargardt. So I'm very optimistic. I know it's going to take time, but that hope and that message to communicate with patients is really important. Um, we know that ABCA4 is super complicated, but we have a lot of smart people working on it. And my last plea to you is that, if you ever see patients where you're like, this is just not adding up, this patient's too young for macular degeneration, or it just doesn't look like macular degeneration, but they've been told they have macular degeneration their whole life. Think of an IRD, think of inherited retinal disease, and even think of Stargardt. And if you have questions, you can always snap a photo and just send it to me, and I'd be happy to chime in. All right, that is all. I will stop sharing.
All
Or you
right.
want me to share, Patrick?
No, you're good. I got it here.
Okay.
All right. Here we go. All right. Great talk, Dr. Fan. Thank you very much for walking us through all of that. I agree. It's such an exciting time in ophthalmology and retina now with all these therapies coming down the pipeline. And yeah, Dr. Fan plays a critical role in our practice, even with our own internal referrals when there's patients with a very confusing presentation, and definitely, hoping to serve you guys to get these patients, the care that they need. So it's a great talk. So how to contact RCTX if you have patients you want to refer. Obviously, you can call in, you can go online. There's a form you can fill out for referring patients. We have methods to fax information over to us. There's a physician on call 24/7 in our practice. We have an on-call team. We do see patients on the weekend, post-ops, and emergency patients. So we're happy to squeeze anybody in anytime that needs retina care. Make sure to follow us on social media. We have a lot of great content on there. Some of it's informative about new drugs and treatments, CE announcements, so you can make sure you don't miss any of these talks, new locations, new doctors that we're adding to the group, patient testimonials, as well as fun initiatives that we have in our practice. And so speaking of that, they added this in for me to talk about. So Driving to Fight Blindness campaign, I've mentioned it before, is fully up and running now. Feel free to check out drivingtofightblindness.org. The fundraising machine is active. So, we're accepting donations. We're trying to get some funding raised. The first project we're trying to tackle with Driving to Fight Blindness is a patient transportation service, where patients in underserved areas or with financial difficulty who can't make it to their appointments or to their surgeries will have a funding source basically to get them where they need to go. Someone lives very far away, needs to go see Dr. Fan for an IRD consult, and they say they can't make it there. This program will make it possible for them to get an evaluation and get the care that they need. We're also planning for a big fundraising event in the fall, so stay tuned. We'll be inviting all of you guys out to that sometime soon. And then just to remind you, so the CE credit's already been submitted just by your registration for this event, 1 hour to the TOB. We will have upcoming dates soon for CE events going forward, so make sure you check back to retinaconsultantsoftexas.com. And just want to make sure to check the chat here. If there's any other questions, we can route them here to Dr. Fan. Let's see.
I don't see any.
Oh, DC children, Dr. Fan.
Oh,
Yes.
that one. I do. Yes.
Yep. All ages.
It'd be nice if they came with like a general visual acuity refraction, because we don't have like refractionists for that purpose. But yes.
All right. Perfect. Lots of congrats there. And yeah, thank you again for the talk, Dr. Fan. Thank you everyone for attending. We look forward to the next RCTX CE talk coming soon. Take care. Have a good night.